Okay, well, I guess we'll go ahead and get started. Um, does anybody have any questions about, I guess, chapter 10 before we get into 13 and 14? Clearly, this is going to be a big shift in information. We're going to be talking about disease, what disease is, how microbes cause disease, and signs and symptoms and stuff like that. Thankfully, not quite like learning glycolysis or DNA replication and stuff like that. So that's what I kind of like about where 13 and 14 are kind of a little bit of a cushion. So we'll get into that today. All right. Colonization, basically how infection and disease are even going to start. That we know disease, that's going to be any deviation from the norm. Okay. Anytime that you are feeling unwell or different or worse than what you should be feeling, that's disease. It doesn't have to be caused by an infection. You know that. That could be caused by genetic things. It could be caused by something like diabetes. It could be, something acquired even still. Something like cancer. All these things are still diseases. But of course, we're talking about infectious diseases here. Infectious diseases are the ones that are going to be caused by microbes. Let me get rid of this. Here. Okay. So in order to kind of understand how microbes can affect our body and lead to disease and everything like that, we have to understand our body. And I'm not talking necessarily about physiology or even the immune system just yet, because of course we're going to be getting into those when we get to chapters 15 and 16. But I'm talking about like, what are the bad guys up against as far as the other microbes acting as defenders or helpers for us in our bodies. So that's our biota, right? And we automatically all think of like our gut biome. That's the more obvious one. But you can have biome almost anywhere in your whole body. You shouldn't have a biome in your bloodstream, right? If there's anything in your bloodstream, bacteria or anything like that, then that's not meant to be there. And the same thing goes for your central nervous system. There shouldn't be anything growing in there. So those would be automatic signs that you could tell if there was an infection or not. But everywhere else pretty much has a biome, and your biome can consist of bacteria, fungi, protozoa, and viruses. And you're like, okay, so all of them. But don't forget, we're missing one, our good old friends, the helminths. The helminths are not on this list, which is where I always like to introduce this concept of, if you go on TikTok, used to be a thing, not as much now, but I think it still is if you look in the right places. People trying to like have you do these special cleanses and even take like deworming medications for like dogs and stuff like that to try to remove the worms that they were saying everybody had in their guts. And they'd be like, see, when I took these medicines, I had these worms come out of my body and whatever. And they would show like, white pieces and whatever. I want to tell you something about those medications. They're really bad for your body because they're eukaryotes that you're trying to kill. You're a eukaryote also. So they're really bad for your body. They're really hard on your body. And so it goes to show that like if you take something like that, it's likely that you're going to slough off the lining of your intestines. It's not hard to slough off the lining of your intestines. It can happen just from having like diarrhea from foodborne illness that isn't a worm or something, right? So it can just happen from other natural exposures. But anyways, those white, stringy, worm-looking guys that they're showing in like pictures or whatever, that's their intestinal lining that's left off. They're not doing themselves really much good there. Also, my other argument with that is if you were somebody that would still be sitting there like, like see the people really do have worms, because that's what their argument is, that everybody has them and they're hiding it from us. I don't know what the deal is there, but I don't know what the argument is. That was the thing, that everybody has them and you don't. Imagine how many people a day in America are having colonoscopies. And we're taking pictures along the way. It's not like the guy is going in there with like the scope and just like taking it back out and being like, didn't see worms. That's for sure. Like that's not what's happening. There's really pictures. And so I don't know where people are getting into this, but that if you don't know, that really was a trend for a while on TikTok, people trying to cleanse their body of helminths, the worms in their body. If God forbid you tell them that bacteria, fungi, protozoa, and viruses are in their body, what are they going to do then? They're going to start taking antibiotics and stuff? Do they know that that's supposed to be part of your body? It's supposed to be there? How do they know anything? That's how that's my argument. People clearly don't know anything. All right, so moving on. Moving on. Why is this not going forward? There we go. Okay. So we learned about the holoenzyme before, about how the holoenzyme is the apoenzyme, the protein with the cofactor, and that's what works as the holoenzyme. So we are a holobiont, it turns out. We are a biotic organism, and our biome that exists within us, biotic organisms, the whole thing, the holobiont, okay? They can do good stuff for us, whether they're breaking down foods for us, helping influence development of organs that more or less is, you have this sort of biome growing in this area. And so your organs are more likely to produce this enzyme or that enzyme or whatever. So that can be pretty influential actually while you are developing as a child. Prevent overgrowth of harmful microorganisms and microbial antagonism. They kind of go hand in hand. Anytime that your biome is basically taking care of you and preventing the bad guys from getting hold, that is going to be microbial antagonism, right? So my favorite analogy would be saying that like there's the stadium seats that are being taken up by all of the good guys so that the bad guys can't come and sit down, right? And if you take an antibiotic, like a pretty heavy one or for a long period of time, and clear out all of the good guy bacteria, then all the bad guy bacteria have opportunity to come and sit in those seats now. So them just being there is part of the microbial antagonism, but also they can produce toxins, not that are toxic to us, but toxic to the invaders. They can also take up like nutrients in the area that the invaders then can't use and all sorts of stuff like that. So they are doing us a favor with that. So when we start having our biome, I'm actually going to go to the next picture because it's easier to describe here. It starts off, we think, in the uterus itself, in the womb. We used to think it was sterile. It says previously thought to be sterile. I think in like the 80s or something, they figured out that we do have a biome in the womb. And that's natural. And that can't be that surprising, right? If you have a biome in the vagina and the womb is just, a cervix away, like that can't be that surprising that there's a biome in there. But it's a little bit different than the vagina because it doesn't have quite the same pH situation and everything like that. And also a little bit different. The baby's developing in the womb. It's getting exposed to the normal microbiome in the womb. And when you're being born, however you're being born, you're exposed to a new biome during that process. Now, if you are going the traditional way through a vaginal birth, then you're being exposed to all of the bacteria in the vaginal area, the vagina itself, as well as the external genitalia, right? And if you're being birthed by C-section, you're not going to be born into a completely sterile environment. I mean, as much as they try to make it that way, pretty soon after that, at least you're going to be exposed to bacteria at some point. And that's whenever you're going to start being colonized, whatever those bacteria are. So completely different experience, of course, completely different bacteria, completely different experience, but still, that's how you get your biome there, okay? Next, we have milk. Breast milk has a microbiome. And then, of course, sterilized baby formula doesn't have a microbiome, right? So breast milk is well known for its microbiome. In fact, there's really, really good bacteria in breast milk that can break down sugars that you can't even break down. And those bacteria will, colonize the baby in the baby's gut. And they'll keep those bacteria throughout their lifetime, and they can help, with breaking down things that they themselves can't break down. And that's, you're meant to have that. You're meant to have that exposure to these organisms. And we also know there's like antibodies in breast milk and all this other good stuff that's meant to be there. One of my students was telling me, it was yesterday, she was telling me that she was homeschooled and that she had, I don't know, I have really bad allergies, I guess because the weather's getting warmer, but she was homeschooled and she had a person, like a mom that knew somebody's mom, or she had a cousin or something. I don't even know what the story was, but they had pink eye. The whole family, all the kids had pink eye. So the mom just took drops of breast milk and put it in their eyes, and it cleared up. That's true. I mean, that's not that surprising either when you know about breast milk and everything, all the good stuff that's in there, the good bacteria that your body isn't going to react badly with, as well as all the antibiotics that are antibodies that are going to be found there. All right. Anyways, then exposure to your care. Oh, right. I do want to say formula. If you were fed on formula, if you have a baby that has to be fed on formula, this happens where sometimes people can't breastfeed. Maybe they're on a medication, or maybe they just can't produce, or whatever it is. They don't have access to, keep pumping and whatever, and they need to feed their baby. Whatever it is, for whatever reason, some people can't or choose not to breastfeed their children. You can still find formula nowadays that has effective probiotics in it, prebiotics and probiotics. So you can still get a healthy microbiome, at least from formula nowadays. And then caregivers, whoever is handling the baby, you're going to get exposed to their biome. That can become part of your own biome. Then we have the environment around you. Of course, as you're starting to crawl, get exposed to the carpet that I'm sure that your parents just completely sanitize every day. And on the ground, on surfaces, and dealing with pets, all of that stuff, you're picking up bacteria and carrying it with you. This is especially true when you're a child, a baby, early on in your life. You don't have a full biome built up yet. So these bacteria that you're getting exposed to in these areas, they're coming to take up your stadium seats because yours are empty. So they're still building up that defense. As you get older, of course, your stadium seats might become full, but that doesn't mean they're always going to stay full, right? We know that just because your pH can change, what you're eating can change, who you're being exposed to, what you're being exposed to, antibiotics, and da-da-da-da-da-da. So sure, you could say it's changing all that during your entire life, and more than you might think, because when you point out situations like, especially when women go through puberty, there's a massive change in that environment in general. That's not because of the bacteria. It's because of hormones, right? So pH change and everything like that. All of that stuff and hormonal changes throughout the menstrual cycle and everything can affect the biome and what kind of bacteria you have. So there's a change there. There's going to be a change for anybody in puberty, but it's just more obvious with females. Also, if you have when you have your first sexual encounter and continue to have sexual encounters with different people after that, if you do, each time that you are introducing that person's biome to yours, you have a propensity for getting a new biome going on, right? At least a new bacteria, something like that. So stuff like that, those are obvious things that you would be exposed to that could change your biome. Of course, if you're sick and get an antibiotic, you're putting yourself in a situation to get a new biome, and that might not always be good. You hear about people who partner and get married or have a long-term partner, whatever it is. And then nowadays, especially now that we're focusing quite a lot on your biome in your body, they're pointing out that maybe the husband or boyfriend or whoever has this biome and the girlfriend or whoever has the other biome. And when the husband introduced this E. coli to this girl, she had not seen that strain before, and her body kind of reacts in an inflammatory way. But now it's part of her biome too. So that can lead to inflammation in the body in general, because now they've incorporated a bacteria in their biome that they are inflammatory against. If you had seen that bacteria early on in life, you might have responded to it and seen it as not a bad guy. But later on, that happens. There's a lot of diseases that they think are associated with that stuff, like hidradenitis suppurativa, autoinflammatory diseases and stuff like that they think is potentially related to that sort of stuff. So something to think about. The more that they do research on that, if you aren't following that, that's pretty much where medicine is leaning. One of the big areas that it's leaning right now is looking into the effects and the importance of the biome and your health overall. And if you don't know, your microbiome in your gut has a huge impact on your mental health. If you didn't know that, it is true. So you can maybe have a propensity to have a mental illness of some kind if your biome shifts that way. They don't know a lot about all of the details, but this is true. It's the truth. So, right, infection, we know this is going to be anytime we have pathogenic organisms. That's important. We say pathogenic, they have to at least have the propensity to be a pathogen to us. Maybe not right at first. Something like staph might be normal on somebody's skin, but we get a shift in their biome and they can become an infection, right? Or transfer it to somebody else, and it could be an infection to somebody else. But it still is a pathogen because it can cause disease, which is the second part, which is any deviation from health. Factors involved in disease, this is not news. Your age, any genetic defects or immune defects, pregnancy, surgery, and organ transplants. Surgery, of course, in and of itself, stressing your body out. And of course, an organ transplant is surgery, like on the big time surgery. That makes sense, but of course, they have to go on immune suppressants for the rest of their lives, literally for the entire rest of their lives. Otherwise, they risk their body seeing those new organs as foreign. And that's always going to be a risk forever. So they stay on drugs to help with that. So if they are suppressing their immune system on purpose, and they're more likely to get sick from other things in the meantime. Underlying diseases like cancer and diabetes, chemotherapy and immunosuppressive drugs for other reasons. If you are on Humira, for example, a lot of times that is prescribed for inflammatory diseases like rheumatoid arthritis, for example. That's just one. But it's an immunosuppressive drug, and that's going to make you more likely to get infections. And then we have physical and mental stress, which I'm sure we are all aware of the fact that if you are getting stressed out physically or mentally, you're more likely to get sick. And then, of course, if you're sick with something else. All right, endogenous versus exogenous infections. Endogenous, endo, inside, right? If you have a hard time with endo, we've said it so many times at this point, you probably don't, but just in case, even things like endoscopy, you're putting a scope inside, endo in scopy, scope, scope inside. So remember words like that you're familiar with as we go through some of this stuff. So this can be caused by biota that is already in the body. That can be due to a shift in the biome, like taking an antibiotic and then another thing overgrowing, or moving a bacteria or whatever into an area where it doesn't belong normally. So those are examples. So here it has Streptococcus pneumoniae. Now, Streptococcus pneumoniae is often carried as part of the normal biota. You can carry it in part of your respiratory biota. That's pretty normal. I think it can be chilling in your sinus cavities and all this. It's normal to have it. It's not necessarily a bad thing in small amounts, kind of like staph, right? Not necessarily a bad thing in small amounts. C. diff is the same way. People just carry it around sometimes. As long as it's not overgrowing, it's not causing a problem. However, strep pneumoniae is also associated with causing pneumococcal pneumonia. It's most closely associated with AIDS patients that are more likely ones to just develop it kind of spontaneously from their own biome. Whereas everybody else would have to be put in a situation where they're exposed to usually a new strain of it. I'll say this about Streptococcus pneumoniae. Okay, strep pneumoniae is pretty ubiquitous, and it also causes a lot of different kinds of diseases. And it's pretty dangerous. It is the leading cause of bacterial meningitis. If you know anything about bacterial meningitis, you know that it's no joke. It's a very dangerous disease, very serious disease. They tell you to get you guys probably got the vaccine. I didn't have to get it in college. They started making people get it after I had left. But the pneumococcus vaccine, that's strep pneumoniae. So that is like if you had to go to college at all and be in a dorm with somebody you had to have. You cannot go live in dorms without the vaccine because they were so worried about meningitis at the time. If you hear about meningitis in populations, it's almost always going to be strep pneumoniae. Of course, then we have another kind of bacteria, which you may have heard of about causing meningitis, which would be Neisseria meningitidis. It has kind of a name in it, but Neisseria meningitidis is the one that causes the rash associated with it. If you know about the one that we get the spots on you associated with it, that's the deadlier form. So I don't remember the exact figures. I'd have to look it up. I think that if you get pneumococcal, it's like 15 to 20% fatality rate, whereas I think like the meningitis one is like the meningococcal meningitis is like 30% fatality rate. That's not a joke, right? That's pretty serious. Bacterial meningitis is bad. So you think it's bad. It's really bad. People, I think, underestimate it. So this is your whole biont, you and the things that live in you, okay? The organisms that live in you. Okay, we have potential pathogens and organisms that can just leave the body. Okay, whatever, they're gonna go away. That's like my normal biome, whatever, my Staphylococcus epidermidis, like a lot of us have. Me leaving it up here on the table, whatever, as I'm touching things. It's probably up here, right? If you were to swab it, you could probably grow it. I don't know. Stuff like that. And some of them might be potential pathogens like staph or whatever it is. So whatever, it leaves your body that way. We also have potential pathogens that would reside in our biome that can cause infection, actually leading to infection. So there, I'm not talking about staph that got away and whatever, it's gone and you pass it, somebody else got sick. Here I'm talking about the ones that are already in your body, actually causing illness in you. You can say the strep pneumonia, that's, I don't think, like the best example. I think a better example would be urinary tract infections. So urinary tract infection, if you don't know, of course, more common in females because of the shorter urethra. That's the truth. And if you have a urinary tract infection, 80% of those, it might even be 90%, at least 80% of them is caused by E. coli. And I mean E. coli from your own body, and I mean your own butt. That's what I mean. So if you've had a urinary tract infection, it was probably E. coli from your own butt. Probably. I mean, really. So they know how to treat that. Doctors know what's going on. They know what's up. They know it's probably E. coli from your own butt. And they give you antibiotic appropriately and whatever. And you're fine and you don't have to worry about it. But that E. coli that was in your butt was meant to be in your butt, not in your urinary tract, right? So it got somewhere that it wasn't supposed to be. It's normal in your GI tract. It's not normal in your urinary tract. So it got somewhere it was supposed to be and kind of overgrew and kind of took over on the maybe weaker guys that were already in the urinary tract, right? Because it has special things that help it survive better in environments like that, all virulence factors. So that's the idea, right? So normal E. coli, we don't think anything of it in the GI tract. It shouldn't be in the urinary tract. Infection and disease even. So we have infection with that E. coli in the urinary tract, that leads to disease. You get your urinary tract infection. You've got urgency to urinate. You've got pain when you urinate. Maybe blood in the urine, probably is, even if you don't see it, there probably is. White blood cells in your urine, foul smell, all of this sort of stuff associated with it. And even maybe back pain if you leave it to go for too long and it starts to migrate into your kidneys. And that's the same E. coli doing that. So that would be disease, right? That's a deviation from our health. However, you can have infection and just clear it and not ever know that you had that thing growing in the area it didn't belong. Maybe you had no symptoms or whatever, and your body got rid of it and it was just gone. You'd never know about it, but yeah, that's your immune system working. Let's say you got disease. Let's say that E. coli caused your urinary tract infection. Yeah, so it could be, not in that particular case, but in other cases, could become part of your biome if it wasn't already. Maybe it was something that you were exposed to new. Maybe it was something already in your biome. Maybe it's moved to another area and now we have it there as part of it because you got exposed to it new. Just depends on the situation, right? It can become part of your biome. Maybe you just eliminate it. You have your disease and you go to the doctor and you drink your cranberry juice and take your pills and your azo and all of this, and you get over your urinary tract infection and now it's gone. Yeah, that's most of the time. However, let's say that you have the disease, you have your urinary tract infection, it's hurting to pee and your back starts to hurt and you're like, no, man, I can't go to the doctor. It's too expensive. Hopefully this will just clear out. You know, Professor Yost says my immune system can do this, whatever. And you don't go to the doctor and you don't get your antibiotics and you don't get treated. And in this particular case, that ends up being a really bad thing for your body because it can't clear it out on its own. That could lead to death if you don't treat your urinary tract infections. I think you guys know that, right? They've warned against it, especially if you get back pain. You really need to go to the doctor at that point, like before you get kidney damage, because the problem with kidney damage is your kidneys are filtering everything from your whole body, and they need to be doing that. If they can't do that, then you start having waste products building up in your blood, and then that can lead to toxic compounds in your blood and everything like that. So whatever. And plus your kidneys, a lot of times when they take damage, it's hard for them to recover from that too. So yeah, if you get back pain with your UTI, please go to the doctor. So this is just going over organisms that would be in each area. I'm not going to test you over that, at least not now. When we get to the diseases, specifically, we'll talk about respiratory diseases and all sorts of urogenital diseases and all sorts of stuff. We'll talk more about the biome. And if it's important and I want you to know it, I'll let you know. But right now, not, okay? Just know that there can be bacteria, viruses, protozoa, and I can't remember what the other one is. What was the other one? Bacteria, viruses, fungi. Okay, there it is. Yeah, yeast, duh, right? Duh. That's the other one, right? You take an antibiotic for your urinary tract infection. right? You're like, oh, I got this urinary tract infection, go take your antibiotic. It clears out your entire bacterial biome, not just the E. coli you're targeting, the whole bacteria. Now all those stadium seeds are open, and the yeast is just sitting there like, well, look at that. And it's going to grow everywhere. And that's a yeast infection. So that's why people are warned, like when you take antibiotics, be sure you're eating yogurt and stuff like that to help replenish your bacteria in those biomes, because you don't want them to all to go away and then you have a yeast infection. And you'd be going back and forth with that, and that would be just a nightmare. So yeah, and it can be. If you haven't experienced it, some people have. So how does this go? You have your pathogen that can cause the disease. We have true pathogens that's what they do. They can cause disease even in healthy people. Okay. Then we have other pathogens. They can be pathogens in the right circumstance, like the E. coli, right? When it moved to that new area. So it needs to meet a certain qualification in order to cause disease. A lowered immune system is one of those, right? So that would be an opportunistic infection. So yeah, so it says here, defenses are compromised or they're where they're not natural location. So that's opportunistic pathogens. They take the opportunity if it is there, right? The true pathogens are truly going to cause disease in everybody. Okay, so let's move on to the biosafety levels. We know a little bit about this. We talk a little bit about this minor in the lab. Our lab, by the way, is a BSL-1 lab, okay? This room, no matter what, maybe Dr. Shearer might try to tell you, this room is a BSL-0, okay? You guys are in here in regular clothes. You don't have to worry about, contaminants anywhere. You're not worrying about cleaning anything up, whatever. So this BSL life is BSL-0 in general, okay? Everywhere you go, BSL-0. Unfortunately, the bathroom, BSL-0. But you get it, right? Your day-to-day stuff that you don't have to worry about, PPE for. BSL-1, like we have next door, you are dealing with things that could potentially be opportunistic pathogens. So you just take precautions just in case. That's basically what it's about. You don't even really have to wear any gloves or anything like that, like we don't. The strains, even the stuff that we're working with, might be called Staph aureus, might be called E. coli, but they are non-pathogenic strains. They don't have any of the genes that allow them to cause infection. So BSL-1, we handle living organisms, and we need to be sure that, we're cleaning up after ourselves and handling things aseptically just for the sake of science and our environment, but there's no real risk there typically. Okay? BSL-2, now we're talking about the stuff that we do over there, but you do want to be wearing gloves. There's going to be biosafety, biohazard signs up, like on the door, and warning biohazard, and you will only be able to be allowed in there if you were taught appropriate procedures for dealing in the area and whatever. But other than that, it's pretty much the same. It's just more signage and more PPE, more strict with the PPE, right? And all that stuff. Like we have that one red trash container in there. So I point over here because in this corner in there, but you guys know what I'm saying. There's a one red trash container. And that red trash container, we just walk everything over to it. Now in a BSL-2 environment, that might be considered a hazard because you're carrying that stuff over to that one can. So we would probably have one at every bench, as well as at that hood that we never use in there, which is for BSL-2 stuff. So yeah, so it's just more precautions there. So what we're talking about things like Staph aureus and E. coli and Salmonella, those things that cause disease, but that actually are pathogenic versions of those. Okay, they do have the genes to cause disease. So that's why you're taking these extra precautions. Next, we have BSL-3. This is taking that stuff and ramping it up even further. We might have special clothing that you have to wear. You might have to change to go in there, because you need to remove that clothing when you leave, right? So they can wear like those paper gowns and stuff like that sometimes in the booties and all of that. There's usually like a dressing clothing area, like when you go in, it's a whole other room, like an antechamber or whatever. You change in there, put on your special gear in there, your PPE, even like masks. Sometimes I know like we have COVID and we wear a mask, but in there, BSL-3, it might be required, right? Stuff like that. And everything's going to be controlled, what's going in, what's coming out. Usually the whole lab, if it's BSL-3, is going to be negative pressure. And what I mean by that is literally the pressure is less in that room than the outside world. So that if there was some sort of contaminant that was like, at risk for being spread into the air, something like that, and there was a break in your air flow and everything like that, air would rush in as opposed to out, right? Because you don't want it getting out. Because we're talking about things like tuberculosis here. Okay, this is tuberculosis, HIV. These things like HIV, yeah, I mean, you have to have blood exposure, you know, blood mixing basically to get it. But once you get HIV, you're done, you know. So we don't want you to get exposed to it. So we have you have, you know, special precautions for that sort of thing. It's not like if you get salmonella, we can treat that. You're screwed if you get HIV. So that's the idea with why we would put those in there. So Coccidioides immitis, if you don't know what Coccidioides immitis is, it is a fungus that causes meningitis. So it's a fungal meningitis. That's a pretty serious one. Up above that, the one that I just drew over, Yersinia pestis. Does anybody know what that one is? That's the plague. So that's the plague, the actual, like the black plague, pneumonic plague, septicemic plague, the plague. That's Yersinia pestis. It's only BSL-3. But and then of course we have tuberculosis, and that's a biggie. That's the lab where I like really learned about like BSL-3 practices. I went to go talk with this guy. I wanted to work in his lab. It was at Berkeley. I was at an interview with him. And he was like showing me his lab, showing me the BSL-3. And it's like they have the antechamber where they change, but it's like controlled. It's almost like you had like doors that were sealing the air pressure. You know what I mean? And so you have to like go in one door and wait for it to seal back before you could go into the next door because of that air pressure, because it's literally tuberculosis in there. So they had all that going on, and it was terrifying for me. That was the very first time that I really saw stuff like that. I was just an undergrad, and I was, you know, interviewing for graduate school. So yeah, but it was cool. I thought it was cool. He did not like me though, so he was one of those professors. He was like, "Do you speak any foreign languages?" And I was like, "Well, I've learned German. I was pretty good at German. I took a few semesters. I don't speak it anymore, but I was good at it then." And he was like, "Oh, well, I need you to know Spanish." And I was like, well, I haven't learned Spanish yet. I would love to learn Spanish, but I learned German. That's what I took for my class. And he was like, "Oh, well, that's not going to work." That was like it. That was that. So, so that was that. That's why I didn't get accepted at Berkeley. I didn't speak Spanish, and that's fine. I know like they would do like trips to Central America and stuff like that, interact with communities there. So it's useful to speak Spanish, but I mean, I wasn't even given the opportunity to learn it. I thought that was kind of poopy, but it is what it is, right? Anyways, I went to an Ivy League school instead, so that's fine. We have BSL-4 next. Now you guys probably know what that one is. We're going to have that full gear. Usually what's going to happen is you're going to go through the same situation that we did with BSL-3, a changing area. And then there might actually be BSL-3 facilities that you might work in related to that. But then you would go through those and then go to another chamber where you would put on these ridiculous suits, you know, the kind I'm talking about, the big rubbery ones. They have like their own like boots that you'll put on. Everything is sealed, and you'll even tape it and like all this stuff, and it pumps air into it so that if you get a break in your suit, air goes out of you. And again, same thing with the room, it's going to be negative, so air comes in if there's a break in that room. Way more highly sealed airflow though in a BSL-4. BSL-4, you'll be wearing those thick rubbery gloves all the time. You'll be wearing a head piece, you know, what do they call it, helmet or whatever, wearing that hood with, yeah, I don't really want to call it, I guess, hood, whatever, you know, with the clear front, and it's plastic, and that's what you wear your whole day that you're working in your lab. And generally they don't come out of their lab because it's a hassle to go in and out. So they'll only come in and out like for lunch and then again for when they're done for the rest of the day. Because it's just a pain, you know, to have to take all that crap off and put it on and whatever. So they usually schedule things around that. But I got the opportunity when I was in graduate school, actually, and finally at Penn, doing my graduate work, I was working on Crimean Congo hemorrhagic fever virus. That is in most facilities a BSL-4 pathogen. Now the Army says it's BSL-3 plus, but you know, they just didn't want to have to deal with it in BSL-4 is basically what they did. They made a rule for themselves. So whatever, that's the Army. You can't do anything about that. So CDC said BSL-4. That's what everybody else says. And so we were working with them, and I was working pretty closely with them that they were doing research on that virus. because I couldn't handle the virus myself because BSL-4, we don't have BSL-4 labs at Penn. They're extremely rare, actually. They're very uncommon. There's only a few. There was like a handful in the whole nation that I could contact and ask them to work with me. And I was lucky enough that they're already doing research on these at CDC. So we were working with them. And so we got to come see their new BSL-4 facilities. They had just built new facilities, and it was on some floor of like their big, nice, beautiful glass buildings in Atlanta. It's really nice campus. And people there, of course, fancy and all this. And just to get into BSL-3, like the whole section where it was going to be BSL-3 and then 4, just to get into BSL-3, you had to do a retinal scan just to get in there. So retinal scan to get in there, and then you had thumbprint to get into BSL-4 after that. So it's like already after that, it's like not everybody from BSL-3 is allowed to go into BSL-4. Yeah, special training. So anyways, we go to BSL-3 and then you go to BSL-4. BSL-3 was already operating at the time. So we get to the BSL-4 portion, and they're like, yeah, there's all these suits lined up that they can put on, and they inspect it and go through the whole process, and they're showing us how it works. And it wasn't active at the time, so we got to go into the lab before they were doing stuff in there. And you go through this little like chamber where it's like going to be pressurized, and you have to wait for the pressurization to take place. You'll hear your have your ears pop and everything as the pressure changes, and then you can go into the lab itself. And you're working with everything just like you would in that lab over there with these big gloves on and this like plastic visor, and like you're hooked up to air, and all you can really hear is the air. You have to have earpieces in just to hear people talking to you and stuff like that. That is terrifying to me. Like that alone, if you made me work just with like puppies in that situation, I'd probably have a panic attack. Like that's going to make me feel so claustrophobic. So anyways, I don't know how that's what I wanted to do. That's what I thought I wanted to do until I saw them doing it and heard them talking about what it was like to do it. And I was just like, yeah, you do it for me. How about that? You do it. I don't want to do it. Not anymore. So they were really nice guys though. And then they would come out when they were done working, they had to go through a chemical shower. So in that same pressurizing chamber, they would have hot chemicals rain on them for like 5 minutes straight, just standing there. Yeah, I can't with that. Anyways, then you can come out and do your whole thing of undressing, taking care of everything and that. And it makes sense how it works. I just, which just seems terrifying. Anyway, so of course, this is going to be Ebola and things like that. So our hemorrhagic fevers, things that can be not too difficult to catch and extremely quickly deadly when you do catch them. Yeah, bleeding out and all these things. So that's that stuff that they will be working on there. They also at CDC keep the official on record United States sample of smallpox. So I'm sure the Army has some too. They were super shady. I got to see their facilities too, but like 90% of their building is classified. So I can't actually go see anything. So like, yeah, your BSL-4 is like five hallways down and to the right, but we can't take you down there because it's classified. Okay, cool. That's what it was like working with the Army. I was working with both of them at the same time. Completely different experiences. So we have virulence factors. So we're talking about virulence. That's anything having to do with causing disease and experiencing disease, basically. So virulence, that is the degree of the pathogenicity. The pathogenicity is referring to causing a disease. How bad is it? That's the virulence. Okay. Virulence factor is anything that contributes to you having the disease, basically. Inoculum, this is having the ID is the infectious dose. Some organisms might just take one of those organisms to on average cause a disease. Other ones might take like 10, 100, whatever it is. For example, a lot of viruses are only going to be one infectious particle to cause disease, whereas like tuberculosis, for example, is 10, and that's still pretty low for bacteria. So polymicrobial, if I need to tell you this, that you can get, pneumonia as a result of being infected with flu. Like the flu doesn't cause it, obviously, but it puts you in a state where you're more likely to get pneumonia. We see them often together. That's polymicrobial infection. All right, how are we starting disease? We're going to go into the person, finding our portal of entry. There's a lot of ways we can get in. Attaching, we have to stick wherever we're going to be doing our thing. Surviving the host defenses, so the immune system in general. Causing disease, So that's going to be, you're living there, you're doing your thing, and you're defending your spot there. And that happens to involve making toxins and things like that that cause damage to the host. And then now you've multiplied and you've got guys that are ready to leave and go infect the next person. And that they need to get out somehow. So that's exiting the host. We're going to go through them. Portal of entry can be, you can get your illness from an exogenous source coming from outside, like we have with COVID, or an endogenous source from stuff that's already in the body, like E. coli, right? So it says a normal biota or a previously silent infection, right? Maybe you had gotten sick from something and it was just hanging out in your body and you didn't know you had it, and now you've got the disease. Or maybe you did, and it's been years, and now it's coming back out again like chickenpox does with the shingles, that sort of stuff. How do you get in? I'm not really going to go through these because I feel like these are obvious. Yeah, you can get in through the skin, and punctures, some things can get in without punctures. The GI tract, you're going to drink or eat things typically. They have to be able to survive. Your microbe getting in that way, you have to be able to survive the pH and the enzymes associated with the GI tract. Into the respiratory tract, you can breathing things in, and that's usually going to be through the nose and or the mouth. You have to be able to deal with the mucous membranes associated there. We have urogenital ports of entry. Most of these we're talking about STIs or sexually transmitted infections. Not all of them, of course. There are diseases that you can have in that area, the urogenital area, that aren't STIs, but most of them are going to be. So you can get through pretty much any organ associated with that. Then we have pregnancy and birth exchange. Okay, we know that between the mother and the baby, we have the placenta, where exchange of molecules from the bloodstream between the mother and the baby are often going to be taken care of there. But you can also cause infections through that mode of transport. So the mother could be ill with something, and it could potentially cross the placenta into the baby. Not always, but some things are able to do that. So let's give some examples. We have an abbreviation for the ones that are associated with it. I hate this abbreviation. I'll tell you why in a moment. So it's TORCH. Okay. The first one, T, is toxoplasmosis. That's the protozoal infection you can get from handling affected cat feces, so the litter, right? That's why we say don't handle litter. Then we have O. That stands for, this is the thing I hate, other diseases. Why are we even listing diseases then? Well, whatever, other diseases, and apparently in their book is going to be things like syphilis, Coxsackie virus, which is the hand, foot, and mouth disease where you get like the rashes. Varicella zoster, that's your chickenpox. AIDS and chlamydia, those all are our other diseases. They don't get their own letters apparently. Then we have rubella for R. You probably recognize rubella as a term, as a name, but you probably have no idea what it is. You get your vaccine for it very early on in life, MMR, measles, mumps, and rubella. Yeah, we talk about it all the time because we talk about measles all the time. But rubella is a viral infection that really doesn't cause too much of an issue with a healthy person. You might not even get symptoms. However, mothers who are pregnant with rubella can transmit it to the baby, and it can lead to spontaneous abortion and stillbirth and things like that. It's very serious. Sort of like toxoplasmosis, but worse. Okay. Cytomegalovirus, CMV. If you've ever donated blood, then you may have gotten a little letter saying if you were CMV positive or negative. That's what they're testing for there. It causes a mild cold in adults, but in babies, it can be very serious and cause serious problems in the fetus. And then we have the herpes simplex virus, which is no joke. Herpes, I mean, it's just herpes, I feel like, in adults that are living their lives and whatever, and be responsible about it and all that. I'm not judging or anything, but you can't cure herpes right now. And you probably won't be able to for a very, very long time because it hides in your DNA. Just like we said with HIV, it's almost impossible to get rid of something like that. We can cause your immune system to keep it in check. And that's what works with Valtrex for most people, and that's fine. However, if you are pregnant, it is a much bigger problem. Not while you're pregnant so much as during birth. Because if the baby is exposed to the HSV, the herpes, during birth, let's say you're having an outbreak on the genitals and you're giving birth to the child through the vagina, and the baby is exposed, and it can get into any part of the body and cause all these problems and real issues and all this. If the baby has it transmit to its central nervous system, which is not uncommon, it's 80% fatality rate. 80% fatality rate just from herpes. So herpes is associated with meningitis, in case you didn't get that out of that. So herpes is associated with a type of meningitis. Most people aren't going to be exposed to it that way. It's very rare, but babies are in that situation when they're being born and new and they don't have an immune system really. That's the problem. So if you were a pregnant mother and you go into labor and you go to the hospital and they're like, it looks like you're having a herpes outbreak, and you might say, oh yeah, well, I mean, but it's lightening up, like I've been treating it and it's going away. They will say, yeah, turns out we're going to have to give you a C-section. And you might say, well, no, we've had a birth plan, like I'm going to have a vaginal birth. The doctor will say, no, absolutely not. Because of that, you don't get a choice then. I don't care if you have a midwife that allows you to give vaginal birth with a herpes infection, report them seriously, because that is extremely dangerous, right? Would you risk that? Probably not. You probably wouldn't allow your patients to risk it either, and you shouldn't. I'm just saying, that's no joke. Herpes, man, when it gets down to that level, I mean, with adults, it's just be responsible about it. But with babies, let's be honest here. All right. Now you got into the body. Now we have to attach to wherever you're going to be growing up. You're going to adhere. You're going to get your foothold on your tissue. This is usually going to be achieved by bacteria, Fimbriae. Remember those guys? They're for attachments like the flagella, but not, right? So flagella for motility, Fimbriae for attaching. Or with the capsule and the slime layer, those sticky coatings. Those can allow for attachment as well. And then we have viruses that can adhere by their spikes associating, remember the lock and key mechanism. Talk about spikes and glycoproteins. So those are attachments. That's what we're talking about. That allows you to get to wherever you're trying to get. And remember, when we have those sticky layers and forming the biofilm, that quorum sensing is going to allow bacteria to communicate with one another. And that aids in establishing infection in infection circumstances, of course. But yeah, here's some pictures of what I said. Fimbriae at the top, capsule in the middle, and the glycoprotein associations with the spikes and the cell proteins there at the bottom. All right, here are some examples you could look through if you were interested of how certain microbes are going to get in, whether they use Fimbriae or slime layer or whatever. This one, I'm sorry, but I have to point this one out. Giardia lamblia, which you guys are going to be looking at, hopefully finding them in the slides. You probably won't. They're really hard to find, but small suction disc on the underside attaches to the intestinal surface. Suction disc. What? I'm just like, look at that. I'm like, they're just protozoa, so they're single cell. So they got this little suction disc, I guess. It's just completely different from the other guys that make way more sense to me. All right, so going on to surviving the host response, we've got phagocytes that go around. I've been mentioning them all semester. The phagocytes that are going around to eat up the debris and the bad guys and whatever they encounter that's not supposed to be there in the body. They're doing this all the time in all sorts of tissues, pretty much everywhere. And they're going to eat up stuff and degrade it, no matter what it is, and then break it down inside of their cells using enzymes. We even talked about the toxic oxygens and all that. Great, that's what the phagocytes do. If you are trying to cause a disease, get established and grow and not get killed so you can make more of yourself, you don't want that to happen to you. So we have something called anti-phagocytic factors. These are virulence factors because they help establish infection. They will either avoid phagocytosis, which we've already mentioned that the capsule helps with that. Yeah, it makes it hard for the phagocytes to eat up the bad guy. Or evading the phagocytic process somehow. So that was this, I guess, counts more of that. So it's going to be capsule here, physically difficult for the phagocyte to engulf them. This one here, adapted to survive inside of the phagocyte after ingestion. That's going to be like tuberculosis. Tuberculosis, its favorite place to multiply in your body is going to be inside of alveolar macrophages. Macrophages are special tissue-related immune cells, phagocytes. So they want to live there. That's where they prefer. So the cells they're sending to go attack the actual, just repeat this, your tuberculosis, and you want to live inside the phagocytes. So your body, though, it sees you're a bad guy, so it's sending phagocytes. Tuberculosis is great. It's like, this is great. Keep them coming. That's what it says. So that's nuts. So some of them do stuff like that. The ones like the capsule here, so it's making it difficult. So, okay, yeah, killing the phagocyte, some of them make like a toxin or something that could kill them, whatever. I don't know much about the specifics on those ones, but I know they exist. So epigenetic mechanisms are another way that we can control the host. I don't need you to know really much about this, other than know that pathogens can potentially make things that control your gene response related to your like immune system typically. So it's like they have those proteins that repress your gene production, like we talked about in our own, like enzyme production. The pathogens take care of that. So that's all it is, hijacking that. Okay, now we're going to cause disease. We've stuck in the place and we're avoiding our phagocytes and we're ready to just multiply. And during that process, typically cause disease. Most signs and symptoms associated with disease are a result of your body fighting the disease, not the thing itself. Okay, that's why the symptoms are so similar between so many diseases. It's just your body fighting it. So, but anyways, virulence factors, remember that's anything that's going to help cause disease, structures, products, capabilities that allow it to cause infection and therefore disease. Let's see. We have guys that can make proteins. We said the collagenase before, if you guys don't remember that one, breaking things down to get in between the cells and the tissues to get to their next location. There's a lot of enzymes they can make like that, okay? Then we have overreaction by the body's defenses, and then the defenses of the host. That's what causes the damage to the tissues. Maybe they are making some sort of product, or maybe they just have a molecule associated with them that triggers the immune system. There's a lot of stuff that can go on there, but if you're triggering the immune system too much, that too much response that can't be regulated because of it, can cause a lot of damage to the body. And then we have altering the host cell genome transcription process. That's the epigenetic crap we just mentioned. So changing what genes are making what. All right, so our enzymes that we could be making to get into and out of these cells. Exoenzymes like the ones that we're talking about, the collagenase, that was one of them. But down here we have mucinase, breaking down mucus, keratinase, breaking down keratin. So it's not, there are a lot of people think of the hair, but your skin cells on the surface of your skin cells are covered in keratin. And then hyaluronidase, and I'm sure you guys have heard of hyaluronic acid, at least probably the ladies have. And it's involved in moisturizing. It carries quite a lot of water, associates with water quite well, but it's also part of your extracellular matrix. So if you break that down, that's just ways for them to get deeper inside of you, okay? Anything that causes, that's produced by any organism that causes damage and therefore acts as poison to you is a toxin, okay? If it's produced by something that's not the organism itself, the organism produces the toxin. And that's a thing that causes damage and leads to disease and illness, okay? All right, exotoxins are secreted by living bacterial cells, and that's just going to be exuded, anything that's exuded that causes damage, like the ones that we were just saying here. These exoenzymes, they're toxins, they're exotoxins too. They're causing disease, right? They're both of those things at the same time. So endotoxin. Maybe you're sitting here thinking to yourself, I kind of remember that word. Because you should, okay? This was chapter 4. Chapter 4 told us that one of the things that gram-negative bacteria have on their outer membrane is something called lipopolysaccharide. We also call that LPS for short. We also call that endotoxin, okay? So endotoxin, it's a toxin to us, right? That's why we call it a toxin. It's just a molecule on gram-negatives in general. And if they, any of the gram-negatives, especially with this exotoxin, it can cause you to get a fever and inflammation. It basically triggers your body if it sees it as like, this is bad guy, time to respond immediately. So it doesn't even need antibodies made or anything yet at that point. It can just respond to that immediately. So endotoxin is part of gram-negative bacteria in general. And these are some comparisons between the exotoxins and endotoxin. You're welcome to look through it, but I'm not going to need you to know that specific of a comparison. We have hemolysis. We mentioned this before. This is enzymes that are breaking down red blood cells. This is just coming back to that, making the whole thing full circle, right? If you can break down red blood cells or not with your enzyme, your exoenzyme. All right, an excessive host response. I keep saying about how that's going to cause damage to the host. It's not just caused by damage done by the microorganisms, like with their toxins breaking down your tissues and whatever else. Like I said, it's often due to interplay between the microbe and the host, and often post-response. Okay. Here's an example down here that it lists long COVID. We think that's caused by an overstimulated immune response to COVID. So people who had an overstimulated response to COVID are more likely to have long COVID. Seems to be associated with it. Okay, there are different patterns of infection that can be established. We have the localized, which is just in one place. Systemic, which is all over. Focal, which is like it got started in one place and moved to another. We have various microbes causing it, so that's a mixed infection. Or we have this next one, which doesn't get its own name, but it's primary versus secondary infections. So our UTIs, for example, maybe your UTI, your bacterial infection, primary, you treated it, now the yeast is overgrowing and you have a vaginal infection of yeast as a result of that. So that's primary and secondary infections. We got that secondary infection because of the primary. So we already kind of talked about these. I'm just going to go through these. I don't need to give examples of all of these. I just want you to know the concepts of them. Primary and secondary, yes, we did. Okay, so acute infections and chronic, if you don't know, acute infections are usually, they come on quickly. They usually have stronger, more obvious symptoms associated with them, signs and symptoms, and they have short-lived effects, so they just last less time. Chronic infections usually have a more muted sign and symptom response, and they last for longer and take a long time to build up typically. Then we have signs and symptoms and syndromes. Okay, definitely know the differences between these. You will be expected to be able to tell the differences, okay? And give examples of each by, choosing the right answer that's given to you. So we have signs. Don't worry, and I'm going to go through this. It'll make it way more sense after I do. Objective evidence. Okay, I'll come back to that. Symptoms, subjective evidence. So these are the two we're going to start with, signs and symptoms. That's why I keep saying signs and symptoms about things. Say objective versus subjective. Now, if I say symptoms are subjective, that's basically I'm telling you that symptoms are based kind of on opinion and what you think is going on, right? It's subjective. What you're experiencing or what we can kind of guess is going on. Signs are objective. That means they are measurable. Okay. Anything that is measurable and observable and you can record it directly is going to be a sign. Okay. A symptom, vague things that you can't actually measure. So here's some good examples. A sign, something you can measure, a fever. Yeah. Also, another example that falls into that category, vomiting. Can you see if somebody's vomiting or not? Yeah, I mean, you're going to know, right? However, symptoms, the subjective part, nausea. Can you see nausea? No, right? Can you see pain? No. How do you measure those? So those all fall into symptom and signs. I always think of like a sign, like a stop sign. It's a tangible thing that you can interact with. I can't interact with a symptom. There's no tangible example of that one. So I can see and prove the sign is there. That's how I remember it. Okay, so those are those two. Those are related to each other. I don't know why I sent them on the same slide, but we're going to go over it now anyways. A disease identified or defined by a certain complex of signs and symptoms. Now, we've already gone over one of them today. I keep bringing it up, but anytime you have a disease that's associated with certain kinds of symptoms, for example, let's say that your symptoms or signs were you're having sensitivity to light and your neck is sore and you've got a headache and you've got a fever. Maybe you have a rash, a petechiae all over your body. I don't know, there might be other things too, okay? Those might be your signs and symptoms associated with it. What disease would I call that? Meningitis, right? So we've been talking about it. So it's meningitis. What causes meningitis? How can you narrow it down to what is causing it in that particular case? No, we've said bacterial. I've already given you 2 bacteria that could potentially cause it. It can be caused by the Streptococcus pneumoniae, most common. It can be caused by Neisseria meningitidis. It can be caused by Haemophilus influenza. If you've ever heard of the Hib vaccine, that's that one, Haemophilus influenza. It's more concerning for elderly patients. And then Listeria monocytogenes. That's another one. It's a foodborne disease. Okay, so those are bacteria. There's some of the bacteria. that can cause bacterial meningitis. We already mentioned Coccidioides immitis that can cause fungal meningitis. Cryptococcus is involved in that as well. And what else? And then viral meningitis. I mean, there's a lot of the viruses that can do that, like herpes, but there's other ones too. Yeah. So we can't narrow it down based on the symptoms because they all have those symptoms, right? You'd have to do further testing to determine what it is. But yeah, so there's syndrome. That's a syndrome. Meningitis, that term is a syndrome. Another one that's really obvious that people forget about, common cold. Yeah. I mean, how many viruses can cause a cold? So many, right? Adenovirus, it can be RSV, it can be rhinovirus, it can be CMV, which I mentioned. There's all sorts of viruses that can cause, there's over 200 viruses that can cause the common cold. But we know the symptoms involved with it. All right, so let's go through some signs. These are some examples of the signs: fever, septicemia, microbes in tissue fluids, chest sounds, skin eruptions, leukocytosis, high white cells, leukopenia, low white cells, swollen lymph nodes, abscesses, tachycardia, and antibodies in the serum. Things you can measure, even using a test somehow, right? Gives you some verification that this thing is happening. What do I want to say about that? And then we have the symptoms, again, subjective: chills, pain, malaise, fatigue, chest tightness, itching, headache, nausea, abdominal cramps, anorexia, and sore throat. Anorexia just means you don't want to eat. Okay. We already said leukocytosis, increase in white blood cells. Leukopenia, decrease in white blood cells. One of the most common things you're going to do if you have a patient who is ill with anything, especially if you're in an ER, is a CBC and like a BMP or CMP, depending on what the doctor wants. Those two things are going to give you an idea of how their like blood system, how their organs in general are holding up, as well as getting you an idea of their immune response too. General picture stuff. So those are, you need those in order to start working on your patient. So we have septicemia. We have microbes multiplying. Any kind of microbe, it doesn't matter. Bacteremia, small numbers of bacteria. Small numbers of bacteria. Any bacteria in the blood at all is bacteremia. If it is flourishing in the blood, septicemia. Okay, it's a different term. And then viremia gets its own term. There's fungemia and all sorts of stuff too. They kind of speak for themselves, luckily. We know about subclinical infections. Have you guys ever heard of typhoid Mary? Nobody hears about this. Yes, okay. So nobody hears about this. Let me tell you the story about typhoid Mary. She was a nice lady. I think she was Irish, and she was happy to be like a cook in a kitchen and serve people food, often working with like soldiers and stuff like that in hospitals and things like that were recovering. And people were getting sick. They're getting typhoid, which is a really bad form of salmonella, has dysentery involved and everything, really bad. And they kept getting sick and sick and sick. And so they started trying to figure out what was going on. And they narrowed it down to she was a carrier of that salmonella strain. She was a carrier. And so they're like, ma'am, you can't because you can't really clear somebody out of that at that time anyways. It's like, ma'am, you can't be serving people food. You got to stop it. So she's like, yeah, cool. And then she moved somewhere else, changed her name, and went back to doing it. People were dying. So at that point, they were just like, no, that's that. We gave you a chance and you decided to keep endangering people's lives. So they locked her up for the rest of her life for 15 years. That's typhoid Mary. So if they've ever heard anybody saying like, oh, you're walking around her like typhoid Mary, if you're like coughing and whatever. Some people come into class because they don't want to miss lab or something like that, and they're like sick with whatever, like typhoid Mary, getting everybody else sick. Anyways, so you can be asymptomatic, subclinical, inapparent. We know that a third of people who actually have COVID, a third of them don't have any symptoms at all. So some of you could actually have it right now. Could be getting other people infected too, but how would you know, right? So, so we're trying to get out of the body. We've multiplied and we're ready to spread the infection. We need to get out. This stuff is obvious stuff, right? You can be spread by coughing, sneezing, the skin lesions, or sloughing skin cells, waste products, urine and feces. We have removal of blood by syringe and or insects removing the blood and transmitting it that way. All this stuff can be related to that. And there's just specific portals associated with these areas. All right, latency, we've mentioned this already. Latency is basically you have the infection and it is still in your body, but it's not actively multiplying, actively causing disease. It's just chilling, right? That could be incorporated in your DNA or could be hiding out in cells like tuberculosis does. But basically, you have that organism there. It can come out later on, right? Sequelae. These are permanent or long-term damage caused by disease. We know, okay, biggest one, I'll get to that in a moment. Meningitis can lead to deafness. Strep can lead to rheumatic heart disease. There's a lot of inflammation that your body could be reacting against. The outside of strep looks like our own cells. So when your body attacks the strep, it can also cause antibodies that then attack your own cells. That leads to rheumatic heart disease. Okay. And then Lyme disease, there's all sorts of crap associated with Lyme disease, depending on who you believe. And then polio can produce paralysis. If you didn't know that, man, I don't know what to tell you. Polio, we don't have it anymore. It hasn't been around for a long time. It's only in Afghanistan and Pakistan. But yeah, people used to have it. They would get so paralyzed that they would have to go in the iron lung. Did I talk about this with you guys? The iron lung? Okay, well. It's not like what hyperbaric chambers are now, where you go in there to get more oxygen to heal your wounds. It's not that. Your heads are out on these iron lungs, okay? Your head isn't in there at all. What happens is there's like a bellows on it that causes the pressure to go, more or less. And your body's inside of that chamber. And as the bellows is moving the pressure more or less, it causes your belly and your tissue of your organs and everything to move basically too, causing pressure on them too. And that allowed them to breathe because they were so paralyzed they could not breathe. So they were just laying there, couldn't even breathe for themselves, relying on these machines. You see pictures of them, they're all like smiling and like, yay, I'm in the iron lung. And people could recover from that. That wasn't always going to last forever. People were able to recover from that if they cleared the disease. Some people had lasting effects, paralysis. You see people who would walk around with canes. Even today, some people still have, you can see older folks who had polio that walk with canes and stuff like that. FDR, if you've ever seen pictures of FDR, he was in a wheelchair because of polio. He always had a blanket to cover it up because he didn't want people to think he was weak or whatever, but he was like that because of polio. So he wasn't sick with polio while he was the president, right? He wasn't sick with polio during that, but he was paralyzed. And that was a lasting effect of having had the polio. So he had polio, cleared it, but still had paralysis as a result. That is a sequelae or sequelae. It just depends on who you ask. I say sequelae. That makes most sense to me. All right. Stages of infection, we have incubation, prodromal, acute, and convalescent. All right, incubation. This has to do with you just infected the person. The person isn't going to have symptoms or anything. Your body doesn't even know that there's organisms in there because they haven't multiplied yet. They're just working on that. Yeah. All right, your first symptoms show up in the prodrome, which is the prodromal stage. I might refer to it as one or the other. Prodrome is the same thing. Then next is the acute phase. This is like full-blown disease, like you have the worst of the symptoms and it's getting to the worst of it, right? Because your organism is growing the most here. It's the happiest, and that's unfortunate for you. You start having a decrease in your symptoms. That is convalescence, okay? I will guarantee you I don't care about this. I know these four and know the difference between them and which one is which. I will ask you, there's 2 questions about it on the exam. Reservoir, something that is where the disease organism is coming from, really. The source is like if you have an outbreak, where that outbreak came from, that person or animal or whatever it is. So those are different things. In general, reservoir is like the in general where it is. Like in bats, something like that. When they say COVID was in bats. It was in China, but it was in the Chinese labs, but that is that. Yeah, so they'd say that, but the source would be like the person that maybe brought it over or something like that. Then we have carriers. These are people like Typhoid Mary who have the disease or the organism and can spread it, but they don't necessarily have any symptoms or don't even know that they have it, right? So you can have all sorts of different kinds of carriers, asymptomatic, incubating, you just got the disease and it's growing. You can be contagious during that time and not have symptoms yet, but still be contagious. Convalescent carriers, you're starting to feel better. How many of you would like have the flu or a cold or even COVID and you're starting to feel better, like quite a bit better? You're not completely over it yet, but you're quite a bit better. So you just decide to go back to work or to class, right? The next day. Common stuff. That's convalescence, but you can still be contagious during that time. So that's convalescent carriers. Chronic carriers that are just holding on to that organism for a long period of time, usually during latency. And then passive carriers like healthcare associated situation. They're not meaning to do these things, but maybe not doing well with their PPE. Living reservoirs can be animals or actively ill people. If I was sick and I cough and I'm handling, it might as well just be the fidget spinner, right? Because I use that all the time. If I'm over here and I'm sick and I like had coughed on this and I don't know, licked it or something, I'd left it up here. And then like Dr. Shearer comes in next and he comes and starts playing with my fidget spinner and he gets the COVID that I had, right? That's an indirect transmission. If I go up to Dr. Shearer and just sneeze in his face, I'm like, oh, sorry, dude, and I walk off. Like that's direct transmission. Yeah, it's just going straight from me to him. There was something in the middle, that's indirect. So this would be a vehicle. And specifically because it is an object that would not normally be infected or anything like that, normally on its own, no disease, right? This is called a fomite. There's a special word for this. Doorknobs and things like that are fomites. We are commonly warned about those, yeah. Sink handles. All right. We can also have, like we said, human carriers and all sorts of stuff, but arthropods, this is going to be mosquitoes, fleas, flies, ticks. They drink your blood and they can pass it on to something else. We have biological vectors versus mechanical vectors. Biological vectors actually are some way involved in the life cycle of the organism. Like we're talking about malaria, we're talking about West Nile virus or something like that. Like that, if it had to go through, like it's actually in the organism and is there and needs that in order to be transmitted. The difference, okay, I keep saying all of these. It lives in rats naturally or something like this. Okay. Now we have a mechanical vector. You get sick from these guys, not because they're actually got the disease in them, but because they ran across some poop and then ran across your food or whatever. Flew and landed on a poop and then flew and landed on your food at the barbecue. That's these, we know that. They're spreading it mechanically. Zoonoses, we know this is going to be anything spread from animals to people, maintained in animals and spread to people, like rabies. I'm not going to go through all of these, but these are all zoonoses. Non-living reservoirs, things that exist in the environment, just in general, like the soil and the water and stuff. Communicable disease is anything that can be spread from one person to another. A contagious disease is going to be highly communicable. Basically, like COVID, was so communicable that we had to have guidelines in place to keep it from being communicable. So that was contagious. Okay, non-communicable. These are diseases that you cannot get like between people. So if you have malaria, right? Me coming over and shaking your hand, is there a risk of me getting malaria from you? No. So that's what I'm talking about. So it can't be really transmitted between people that way. Or even like if you fall and scrape your knee and it gets infected, like that's another thing. So horizontal versus vertical. This is horizontal. I'm going to just start with this. Vertical is like mother to child. Okay. So it's going to be the parent to the offspring via ovum, sperm, placenta, milk, something like that. Okay. That's vertical parentage going on there. Horizontal transmission between organisms that are not that situation, not parent to child. Okay. So here we're talking about the direct and the indirect transmissions, like me giving Dr. Shearer COVID through my fidget spinner or something like that. But that's horizontal transmission. If I explode right here and all my Ebola just goes everywhere all over the room and you guys all get Ebola, that's horizontal transmission. And unfortunate for you. It would be direct too. Okay, vehicle, right? So it's a vehicle, anything that can be used to transmit the infection. A fomite is an inanimate object that will transmit the pathogen, but is not a source of the infection. Like we said, not normally going to have COVID associated with it. So we had to put it there. Oral fecal route of transmission, eating and drinking things, water and soil, we already said, and air, cool. Droplet nuclei and aerosols, sneezing, that stuff can hang in the air for hours, dude. Depending on the microbe, it can be like 8 hours hanging out in the air. Imagine if I cough in here and then 8 hours later, Dr. Shearer walks through it and gets my tuberculosis. That's crazy. So, yeah. Koch's postulates. Robert Koch came up with these steps in order to identify what they call an etiological agent, so the causative agent of an outbreak, right? So what he did was he took sample from patient and plated it and separated it out, right? And then took each of those different kinds of bacteria he got and put them into mice. And if they had the same symptoms, then those were the ones that he would re-isolate the thing from. And if it was the same thing, that was the cause. Okay, so it's basically like, hey, people have this disease. I'm going to take a sample from it, see if it happens in mice. Oh, it did. Okay, this is the organism that causes it. Do I get that same organism back out? Oh, I do. Okay. That's how he discovered anthrax, the cause of anthrax. Whew, those are called Koch's postulates. Okay, all right. And then our question of the chapter is going to be give an example of a syndrome. And sorry, that's supposed to say a disease. I just keep forgetting to amend it, but whatever. Not that you guys are going to do it anyways. Give an example of a disease or pathogen and list associated signs and symptoms for it, you know. So start thinking about things that way, especially as we get into unit 4, you're really going to want to be aware of how these, you know, things work, these mechanics work together. Any questions? It's a lot, but it's not too hard, this stuff, I feel like. Anna, I don't know if you're still there, but if you are, I'm just gonna let you know that if you do, and if anybody happens to participate like through Zoom in this, like usually if you're gone, I'll have you like do the Kahoot to make up the points. But if you actually participate through Zoom, you can just take a picture of this at home and post that. That's fine. Because you did the same thing as everybody else. So. All right, I'm gonna go ahead and close out of this. I hope that's all right with you.